So pancreatic neuroendocrine tumors can be very challenging. One, it's an uncommon cancer. It's not as rare as people think. In general, neuroendocrine tumors, probably about 8 to 10,000 patients with neuroendocrine tumors that are diagnosed a year. But the prevalence, the number of patients living with our disease is actually quite high. It's higher than pancreatic and gastric combined. And that's because our patients can live for many years. So unlike other patients that I care for where their overall survival may be on the order of just several months, our patients thankfully can live for years. But many of our patients won't live for many years or many decades like they deserve. So that's my responsibility to try to understand, first and foremost, who are the patients that I need to be worried about, but also who are the patients that maybe can do very well, almost die with the disease because of the disease. And that's actually possible with our cancer. So distinguishing who the patients are that have the cancer that's going to cause trouble is imperative in this very uncommon disease. So what do I look for? So the first thing that we look for is actually what the cancer looks like under the microscope, because the grade or the differentiation or morphology of the cell can really help me predict how well or unwell that cancer may behave. So tumor morphology and grade of the tumor is critical. A low grade or mature cancer, or pancreatic neuroendocrine tumor, those tend to do the best, whereas an intermediate grade or high grade cancer has a much worse prognosis, unfortunately. So the first is a pathology. The second thing we look at is actually, does this tumor make a hormone? If it does, we call that a functional tumor. So functional hormone related disease can be debilitating to our patient. The quality of their life can dramatically change because of these hormones. And each neuroendocrine tumor can make a different hormone. So for example, the so-called carcinoid tumors can make serotonin, which can manifest as flushing or diarrhea. And those symptoms can be debilitating for our patients. Whereas pancreatic neuroendocrine tumors can make hormones such as gastrin, which can cause ulcers, insulin, which can be life-threatening because of the very low sugars, or other rare types of hormones such as VIP, where they cause refractory diarrhea. So trying to from the beginning understand, does this cancer make a hormone or not, is pretty critical for me because it helps me better understand how quickly I need to treat them. So any patient with a hormone-secreting tumor should be treated earlier rather than later to one, improve their symptoms, but also control that hormone. And then the third thing that we look at is the burden of disease. So patients with a lot of disease, particularly in the liver, we tend to treat much earlier than a patient with what we would consider sort of asymptomatic or incidentally found disease that can often be very small volume. And those patients we can actually watch pretty carefully in the beginning to actually consider observation as an option. So those three things can be pretty important for us to better define who should be treated and when.